So on to testosterone, which there are always lots and lots of questions around. So could you talk as an overview about what the role testosterone plays in women's bodies, and subsequently, when we go into peri and post-menopause, not every woman will need supplemental testosterone. Some women it's more important than others. Can you just talk about that generally, because we don't often hear testosterone talked about with regards to women's health?
Not enough. And I think you'll agree with me that not everyone knows that testosterone is a female hormone. It's often talked about as the male hormone.
Almost always written about as a male hormone as well.
The other fact that's not known is that women premenopausally produce 3 to 4 times more testosterone than they do estrogen.
Yes.
So it's very much a female hormone. And we know that one of the most important functions of testosterone is that through dopamine in the central nervous system, it modulates sexuality. So not just libido, so not just sexual desire, but arousal and orgasm.
Yeah.
Now, I'm not saying that testosterone levels fall off the edge of a cliff with menopause. They don't, not through natural menopause. But there is this gradual decline, again, which seems to mirror the decline in ovarian reserve,
yes,
and the production of testosterone from the ovaries. But particularly does fall off a cliff, 50% is lost after surgical menopause.
Yes.
You know, if the ovaries are removed. But as well as the sexuality parameters, we know that testosterone receptors almost entirely mirror the estrogen receptors in the female. So there are testosterone receptors in the brain, in the cardiovascular system, in the bones, in the urogenital tract.
Yep.
So any benefit that you can think of with estrogen, potentially you can also get with testosterone as well. But there are differences, there are subtle differences as well. Testosterone doesn't seem to be in women as important as it is in men in protecting against osteoporosis.
Yep.
And estrogen is more important in women from that perspective. The urogenital tract, we know that testosterone can have a benefit independently of estrogen in protecting the collagen, the elasticity, the lubrication of the vagina, for instance, and the vulval area. In the brain, we know that as well as improving as well as improving sexuality, it can improve mood, it can improve cognitive functioning, and modulates for that very well. And we know that in the cardiovascular system, whilst there have been some concerns about whether testosterone might increase the risk of breast cancer, in fact, some studies suggest that it helps to balance the rate of breast cell proliferation to what we call apoptosis, so programmed cell control, so that there is this balance maintained. So there's a lot that we know about it, but there's a lot that we still need to know about it. So, for instance, in the trials that have been performed, very few studies have been done to look at the impact of testosterone in terms of mood, in terms of bones, in terms of the cardiovascular system, in terms of the urogenital tract. We need to do more research from that perspective to prove what we think from the physiological perspective, that it would be valuable to supplement in terms of those parts of the body. What we can say definitively from the randomized trials that have been done, and I've been working with a collaborative group led by Professor Susan Davis, who's currently president of the International Menopause Society from Melbourne, over 8,000 women who'd been randomized to either testosterone or placebo. We know that from those studies that there is a statistically significant improvement in sexuality, in sexual desire, in sexual episodes, and improvement in arousal and reduction of distress associated with those symptoms. with minimal side effects.
Mm-hmm.
Minimal. So, no beards and moustaches, a little bit of excess hair growth perhaps, or maybe some spots in those whose levels were a bit higher.
Mm-hmm.
The studies did not show an increased incidence of heart disease or breast cancer, but we have to accept that we need longer term randomized trials to prove that definitively. So cutting a long story short, I think testosterone should be offered to women alongside estrogen and progesterone when we're talking about hormone therapy. But as you know, what we lack are licensed options, not just in the UK, but globally.
Everywhere,
So we're having to use titrated down doses, 1/10 of the male dose to achieve a physiological female dosage. So we're telling women to make a sachet of testosterone gel for male use or a tube to last 10 days rather than use it daily. Or the pump dispensers, use them every other day or every 3 days rather than daily. It's not ideal.
No.
We do have a product called Androfen, which is indicated for female use, but has to be imported from Western Australia, and is not available in every pharmacy, is not available to prescribe on the NHS. So it's far from an ideal situation. Until we get those products, until there are licensed options and people feel comfortable using those, then I think women are not going to be offered it regularly. And as you know, sometimes it can be the missing ingredient.
Oh, it absolutely. Personally, as you know, yes, it absolutely, for me, after surgical menopause, absolutely was. It was as if somebody had removed a chip from my brain, and then you prescribed it back for me, and within a few weeks it made a huge difference. Absolutely huge. Just briefly, could we just talk about particularly the younger women, the surgical menopause, the POI women, and how important testosterone potentially is for those women?
I'm glad you brought up the issue of POI, because POI, premature ovarian insufficiency, which is the sort of technical term, if you like, for premature menopause, is going to be the main subject of World Menopause Day for the International Menopause Society. And we've produced a position statement for that. And we're going to have patient materials, women's materials as well to disseminate. We're working with DAISY Network, which is the premature ovarian insufficiency support group that I'm a proudly patron
They're a
of.
brilliant charity. They're fantastic. They do amazing work.
And we know that hormone replacement in women with POI is so important, because it's not just about maintaining quality of life and alleviating symptoms. It is about reducing that risk of heart disease, osteoporosis, dementia, etc. That hormone therapy should be used at least until the average age of the menopause. Now, with surgical menopause, we've said 50% of a woman's testosterone levels are reduced. The other 50% comes from the adrenal glands. With POI, even if it's natural POI, we know that testosterone levels are lower in that group as well, compared to sort of age-matched non-POI controls. And so it is a very important hormone to consider, particularly in that age group. And it may be important not only from the sexuality and maintaining the relationship perspective, but there's also some evidence that it helps in terms of if there is any ovarian reserve remaining, creating the optimum environment for any remaining eggs to be ovulated.
Ah, really? How interesting.
And although fertility is hit very hard by POI, and chances of pregnancy are reduced significantly, if we can at least optimize the hormonal environment, that gives the best opportunity for women to try to achieve a pregnancy with their own eggs before moving on to donor eggs, for instance, as the more reliable way of achieving a pregnancy. And we know that egg donation is not for everyone, so I think it's important that we optimize the environment as much as possible for that individual, give them the best possible chance.
So for women who are in a natural menopause, Nick, so let's say you've got a woman who's, 45, she started on estrogen and progesterone, she still has her womb, and she's been on it for 6 months, and then she's still experiencing issues with libido, with cognition, with her sort of her outlook, etc., which we know that testosterone can help. For that woman to if she's in front of a doctor or a specialist who can potentially prescribe her, how should testosterone be monitored? Is it monitored in the same way as, sort of maybe an annual appraisal of your HRT, or should testosterone levels be checked more regularly to see, kind of that they're being kept at optimum?
Yeah, I think the first thing to say is that, I try to avoid sort of fancy terminology in these interviews, but we need to have a sort of biopsychosocial approach, don't we, to these situations. So we've considered whether there are relationship issues, whether there are other medicines that may be interfering with libido. Antidepressants, for instance,
yes,
are potent.
Yeah, absolutely.
The pill.
Yep.
Because we know that estrogen from the pill increases the levels of the SHBG protein, sex hormone binding globulin, which then can mop up free circulating testosterone. And actually, that's the other thing to say. When HRT is being used, it's much better to use estrogen through the skin rather than orally if there's low libido.
Yeah.
Now, when we're monitoring the levels, although we do a baseline level, it's really not to say you've got a low testosterone level and therefore that's why you need testosterone, because sometimes people with low testosterone have got perfectly normal libido, and they don't need to have it replaced.
Because it's complex, isn't it?
Yeah, absolutely. John Studd always used to say heart, head, and hormones, as he covering all that biopsychosocial approach. But we check it so that when we then recheck it, first of all, we can see, has there been a change, an improvement in levels? If there hasn't, then maybe one of the reasons that that person's libido remains low is because the levels have not gone up. But also to make sure that we're not giving too much. So if you have somebody who has normal or high levels to begin with, then you don't want to give them more.
Yeah.
That is more likely then to lead to excess hair growth or spots.
Yeah.
In the consensus statement that we drew up, we said that ideally levels should be checked by 6 weeks on treatment, but realistically, we see women after we start treatment within 3 months, and I think it's reasonable to do it at that stage. And then I will typically check it again after 6 months, and then usually 6 months after that, and then depending on how stable things are, an annual assessment may be sufficient.
Yep.
If you go by the consensus, it says check it a couple of times a year, but I think as long as you know that the levels are stable and you're doing that annual review, I don't think you necessarily need to do a 6 month review. But it's all about individualizing, isn't it? It's all about working out, right, are things absolutely perfect? In which case, there's no need to monitor as intensively. Otherwise, let's do it more often and make sure that we're not giving too much or too little. But in terms of duration of usage, we make the same assessment as we do with estrogen, progesterone, whether we continue with testosterone long term.